Anyway, if yes, then please turn on the camera. Okay, so that's Liam. So just a couple of announcements. So this is the first time we will have our new module started. So we will have every third Thursday of the month consultant teaching, as you all requested. So the first one is Liam, and then it follows afterwards. And then we also incorporated simulation in the teaching activity. The first simulation, if you can make a note of that one, but it will be on your WhatsApp chat group as well when the time is closer, is going to be on the 9th of February at Northwick Park at the unit. So it will be an on-site live simulation on the 9th of February. So whoever is there on duty will participate, including our lovely nurses as well. And I encourage everybody who is off day to come along, and then we will do a 2-hour session with at least three in 3 sittings. So it will be fun, and it will be something very unique. Not many ICUs or actually not many hospitals in the ICUs are doing that at all. That's it. So we are going to note. Tuba, are you on the call by any chance? I'm sure you're busy, but you might be on the call. Just please, in the chat box, can you please write your name if you're on the call, so we can do our regular register for the session. That's it for me. It's for Liam now to take the floor. Please.
Thanks, Ferenc.
Thank you.
Can you hear me okay? Right. Let's close all this. Can everybody hear me all right? Or not?
I can hear you. I can see you.
Great. Okay. So I got my slides. Right. Okay. So thank you for asking me to come and talk on renal replacement therapy. It's a bit of a sort of nebulous thing, but useful, as we all know. So in terms of where we start for this, it's covered in both the syllabus. So you've got syllabus. You've got a couple of sections here. So the first PB and the PC bits, they're from the Royal College syllabus, and obviously they can examine you both at the theoretical level and in the Viva on these things, mainly part 1, but it crops up sometimes. I got asked about acute kidney injury in my Viva in part 2. And then the FICM syllabus has quite a big section 4.7 on this area. So initiates, manages and weans patients from renal replacement therapy. And then, of course, there are some perioperative considerations. We do, this is, I know, predominantly an intensive care thing, but obviously patients that we see on intensive care are post-op, and there are some issues around CKD patients as well. They are overrepresented in the surgical population, and it does cause an increase in all-cause mortality. And as you can read there, a few other morbidities. So, part of the impression that we would like to make on our anaesthetic colleagues is to give a good anaesthetic, essentially. Just a very quick snapshot of things that might affect acute kidney injury, and these are in the sort of operative side of things, really. It kind of applies to medical things as well. So you can see there you've got your existing on this side. Let me get a little pointer up here. It might be better. So on the here we go. So on the preoperative side, you've got pre-existing kidney dysfunction, and then the usual risk factors. Patients we see a lot of on the ward for medical and sepsis, they're often volume depleted. We've seen quite a bit of hepatic failure in the last couple of months. That'll probably continue as the sort of people have been hitting that booze hard during COVID as finally sort of presenting themselves. So, and then we've got things that affect your intraoperative patients, but they're also sort of similar to medical patients as well. Hypovolemia, kidney ischemia, either from sort of vascular insults or as a result of hypotension from sepsis. And then all these other sort of factors related to the anesthesia, which not particularly dramatic, but it's worth bearing in mind that there is an increased risk of an AKI if you have a sustained MAP under 55 during your anesthetic. So and that does have an effect as well on other patients from a medical perspective as well. And then you have your post-operative affections. We expect people to get inflamed post-op or following sepsis, and there are other sort of things there that can affect the perfusion of the kidney. You can increase these, as you can see, these things reduce blood flow and increase oxygen demand. And normally a kidney, especially at the loop of Henle, is running pretty hypoxic at the best of times. So as soon as you drop blood flow and increase oxygen demand, you can appreciate why a kidney would then decide to sort of go into apoptosis, and or certainly some of the cell lines in the kidney go into apoptosis, and you lose renal output. So that's just a brief bit. We shouldn't really move on to dialysis without talking about the definition. You've probably seen this before. There's the rifle, risk, injury, failure, loss, and end stage classification. You've got the Aiken classification as well, which I've got here. Again, it doesn't. They both correlate. Again, this sort of way of assessing patients. It was really to standardize the research into acute kidney injury. But it's a good sort of marker to tell you which way these patients tend to progress. So 1.5 to just under 2 times baseline rise in creatinine, or more than 26.5 increase, or urine output less than 0.5 ml per kilo for 6 hours tells you at stage 1. You might be able to rescue those people at that stage. And often these are the sort of patients we see in resus where they call us and say they've been in for 2 hours, they got no urine output, and you come down to find that they've given them 0.5 litre of fluid, and they often remediable with a bit of volume resuscitation or maybe even increase in cardiac output. And then the stages of your AKI progress depending on how your creatinine and your urine output goes. So reasonably easy things to measure, and things that we could potentially treat early if we're called early. So that's the definition. Now, the causes of AKI can be divided very simply, and I'm not particularly complicated. You've got pre and post causes, so things that cause hypovolemia, whether that's redistributive shock, whether that's hemorrhage or just dehydration. Hypotension, again, they sort of are linked. So that could be because of left ventricular failure. That could be because of volume under resuscitation or volume loss. Though those probably account for the vast majority of your acute kidney injury in these patients. Post-obstructive, post-renal causes, so obstructive causes, are about 10%. And so things such as prostatic hypertrophy or bladder outflow obstruction for various reasons, like tumors or hemorrhage or something along those lines. Or there could be tumor obstruction further up the chain, where one kidney might not be functioning and the other working kidney gets obstructed. So those are sort of important considerations, which is why it's always useful to have an ultrasound of the kidney, or if they've had a CT scan of the abdomen for other reasons, we can have the size of the kidneys and the outflow assessed to make sure that there isn't something simple that can be done to improve the patient's renal function. And then the small minority then of the patients who get AKI can be caused by intrinsic causes, and these are the sort of territory of the nephrologist or the PACES examinee. And these can be due to vascular causes, such as a vasculitic process, such as lupus, things like of that nature, or thrombotic diseases. There are quite a lot of tubulointerstitial diseases that are caused by drugs like penicillin, cephalosporins. If you're on a proton pump inhibitor in the community, you've got an odds ratio which is about twice the baseline of getting an AKI. So there is an association with proton pump inhibitors. Non-steroidals are a classic one that we should be stopping stop all nephrotoxic drugs. Streptococcus and Legionella also cause sort of intrinsic renal problems. I think usually at the tubular interstitial sort of situation. And there are there's quite a long list of other things, radio contrast agents and that sort of thing. So you can always look those up if you want to be specific about what kinds of things might be driving this. But our friendly neighborhood nephrologist has usually got got those on their fingertips. So those are things to think about. Anybody who's got a renal function that's suddenly deteriorating, particularly in the sort of context of nephrotic syndrome, you should look for renal vein thrombosis because they are a bit more prone to that sort of thing. So I remember the way to initiate dialysis based on the vowels, okay? And I've put H in there because it technically isn't, but it's there. So this is what it stands for. I have fudged the I a little bit, but essentially we have acidosis, electrolyte disturbances, toxins, edema, uremia, and hypothermia. Now, we don't see much in the way of uremic patients as they would have done 20, 30 years ago, certainly in this country. We have had a few corking patients coming in the last couple of weeks with ureas of 70 something. But that uremic frost or the uremic comas that used to be described in books are a bit rarer in this country because of access to healthcare, but it is seen in other countries. And I'll talk about hypothermia a little bit. I think I talk about it a little bit later on, but those are the main ways I sort of phrase indications. So you can look at a threshold for acidosis, and the books sort of talk about pHs between 7.1 and 7.2, but certainly when somebody's presenting with a metabolic acidosis that's driving a pH of 7.2, because there could be a respiratory component, as we often see with some of these patients who've got type 2 failure on top of having an AKI. But that's those sort of thresholds of a pH under 7.2 and a bicarb below 12 to 15 should prompt a consideration for, does this patient need some renal replacement support? And then electrolytes are, the books talk about potassium above 6. Some patients will tolerate potassiums a bit higher than that, but 6 is a reasonable line in the sand for when you start to think about moving them somewhere where dialysis or filtration can be initiated. The old classic one here, as your potassium rises, you get into this terrible sort of sine wave and cardiac arrest situation. Your T waves get more tall and tented, and your QRS gets wider. These are pretty classic. About 50% of patients with hyperkalemia show ECG changes, so they're not particularly sensitive for electrolytes. So even if your ECG is reassuring with somebody with potassium of 7, you should still be wary that these patients could become cardiovascularly unstable. So you might want to give them some medical therapy to start with, dex insulin plus some calcium to stabilize them. But you might want, if you do certainly see somebody with an ECG change, then that's obviously significant, but it doesn't always show up. And you can get other things. You can get AV blocks, you can get escape rhythms, you can get bradycardias, you can get AF. So they're not always classic ECG changes. So that's ECG changes. Now, other indications, we've talked about those main ones, and then we've got edema. And again, if you think back to our patients that we see in resus or even on ICU that perhaps have had a filter holiday for a bit or have started to get a post-op AKI. Edema is one of the things that we often concern ourselves about. There may be patients who are not responding well to diuretic therapy over the last couple of days and their fluid balance is positive and they're boggy everywhere, or people present acutely with pulmonary edema. And that will be an indication then for getting some fluid off. And then anybody with symptomatic uremia, and as I say, it's not as common to see these sort of things, but they are described, and you do see it occasionally. I think ICU patients seem to be a little bit more sensitive to rises in urea, probably because they're just generally unwell. So sometimes patients who aren't waking up with ureas of in the sort of mid to high 20s sometimes do a bit better when you filter them down. And I sort of use that as a I suppose a test to see if they wake up when the ureas are back to normal before doing all the other tests like EEGs, CTs, and that sort of thing. And then the other one I fudged for the bowels is toxins. So this is a short list of things that can be dialyzed out, and it's worth remembering if you know the pharmacokinetic numbers for some of these drugs, you can pretty much work out whether they'll be dialysable. So pretty much any drug with a volume distribution under 1 litre per kilo should be dialysable. So aspirin, lithium, barbiturates, and aminoglycosides and things like that. We don't see as much overdose in Norfolk for some reason, but these are things to think about. Ethylene glycol and methanol. There are other things that we can treat now. We've got famipazole, which is an alcohol dehydrogenase enzyme inhibitor that can reduce the production of the toxic metabolites in ethylene glycol and methanol. But if these can be measured. So if your ethylene glycol levels are above 700 milligrams per liter or so, you should be dialysing them. If you're giving them famipazole as well, they should be dialysed until those numbers get better. It's a bit lower if they've had alcohol, and if they haven't had famipazole, then 500 milligrams is said to be the sort of threshold with which you should start dialysing them, and that's based on some work by the XTRIP working group, who are a group of physicians look particularly at extracorporeal removal of toxins, and they've done quite a lot of work on finding drugs that are dialysable. So that's sort of that's the sort of main thing. So you can always look these VDs up in the literature to work out whether this might be a useful therapy to apply to patients. So at this point, just wonder if anybody had any questions before I moved on to the next bit. Right. Okay. So Belomo is an intensivist in Australia, and he's published an awful lot of stuff on dialysis over the years, and he defines renal replacement therapy. Now, if you're doing a Viva or doing any exam, always have a definition. So it's an extracorporeal blood purification therapy, which is intended to substitute for impaired renal function. And we tend to divide these therapies into sort of intermittent or more continuous. And on our ITU, we actually have the option to do a couple of these. So the intermittent therapies are those therapies that you add for, technically by definition, under 24 hours. So you have intermittent hemodialysis, which is what we've got plumbed in upstairs, and it's what the outpatients dialysis units tend to do. And those can be anywhere between 2 to 4 hours, usually about 4 hours, and they can be extended a little bit longer to 6 hours, depending on the patient and how much fluid needs to come off. Then you've got slow, low efficiency dialysis, which are sort of therapies that you can take fluid off and electrolytes. and they can be run for a longer period of time as well, but usually under 24 hours. And then we've got our continuous therapies, which are ones that we're a bit more familiar with on ITU, where these things are run for more than 24 hours. And that is sort of broadly defined into the slow continuous ultrafiltration, and then all the way up to the sort of modality that we use, which is continuous hemodiafiltration. And we'll talk about that in the next couple of slides. And then there is peritoneal dialysis, which again, it's not something that we see at all on ITU. There isn't a lot of uptake in this country with peritoneal dialysis. Essentially, peritoneal dialysis involves putting a permanent catheter in the abdomen and using the peritoneum as the filter. Fluid is a certain volume of fluid is instilled into the abdomen, a period of time is waited, and then that fluid is drained. And you can get very good clearances with that. And there are two types of peritoneal dialysis. Essentially, you've got something called continuous ambulatory peritoneal dialysis, where somebody sits there watching fluid go in, and then it's poured out. That can be done in an outpatient sort of setting. And then there is automated peritoneal dialysis, where patients hook themselves up to the fluids overnight, and they get a dialysis session overnight. Those machines are expensive, but people do buy them and have them set up at home. There is possibly a suggestion in the literature. They're not particularly great evidence base apparently, but some of the observational studies suggest that peritoneal dialysis might have some survival benefits over hemofiltration in the first couple of years of therapy. And so some centers will recommend patients start on peritoneal dialysis before they start on more of a hemodialysis, but that's not something that we see so much in London. But I think the Canadians do more peritoneal dialysis as initiation therapies than they do intermittent. I think it's 50% in Canada versus 7% in the States. I don't know what it is in this country actually. But anyway, so that's something you might see. You might see. So, but when we're considering the filter, we need to sort of decide, we need to consider some of the physical things that happen to the patient during the process of initiating therapy. So you've got three processes. You've got ultrafiltration, convection, and diffusion. So with ultrafiltration, you get movement of plasma water across a semi-permeable membrane driven by a pressure gradient. So it's a sort of like putting something across a sieve, or if you've made cheese against a sort of muslin. So you squeeze out the fluid, you need a bit of pressure, it will squeeze out fluid, and what's left behind is your blood components with a bit less plasma and lower levels of electrolytes that you're concerned about. And then convection is the solute transport across a membrane dragged by the fluid movement caused by the pressure gradient. So your ultrafiltration moves your water, and then with that you get convection, which then moves your big molecules across. So you get your urea, sodium, potassium, and your other electrolytes like phosphate move with it. And then with diffusion, you've got solute transport across a membrane, which is generated by a concentration gradient. So with the first two, you've really got a sort of pressure gradient that drives water, and then that pulls sodium and the other things with it, as it said. And then with diffusion, you maintain a concentration gradient, which allows fluid to electrolytes to move across. And that's where the dialysis bit comes in, and we'll talk about that in a second. So just briefly, my sort of slightly homespun diagram here of a filter. We've got blood. Where's blood coming in? Blood's coming in the red end. Okay, so if you remember the pictures that you've got of the filters in the the filters at the red side, they've got large polycarbonate containers, and in them are packed with lots and lots of fibers, which are these very, very small microtubules. And the blood flows through the center, and because of the porous nature of these fibers, fluid and electrolytes can move out. The type of electrolyte size is determined by the makeup of the fibers. The fiber material depends on the intended use, as said. So I think Baxter's got an acrylonitrile and methyl sulfonate copolymers, and I think Fresenius uses something similar as a polysulfone membrane, which allows large molecules to stay in and allows big molecules that we're interested, like creatinine and urea, potassium, to cross the filter. They do have a few high flux filters which are slightly more modified to do other things like modulate immune responses and things like that. So blood goes through here, there's a pressure gradient against that. Then as the blood moves through the tubes, fluid is moved out, and fluid comes out through here in the yellow one here. The green one is where the dialysate goes in, and this one is where the dialysate and the effluent comes out. So that's a sort of like essentially a pressurized sieve, for want of a better word. You can see here how fine these tubules are, and what the ultrastructure looks like. So they're almost like the glomerular, the basement, the glomerulus in terms of their sieve-like structure, but nowhere near as sophisticated, but still a pretty good. So let's just move on to the different modalities, because I think that throws people sometimes when you see these patients. So we've got SCUF, which we'll talk about first. So SCUF is essentially slow continuous ultrafiltration. It is probably the simplest. If you were building a dialysis machine to treat patients, if you've not made a hole in their abdomen and poured fluid in to do peritoneal dialysis, this would be the one that you could build next, with a few pumps and a few things like that. Not recommending it, but this is the building block for the other bits that come. SCUF is good for managing fluid. It's not great for managing high urea loads or high acidosis burdens or any of that sort of thing. But we tend to bring patients down to SCUF as they are progressing in their illness, and we've perhaps dialyzed them hard at the beginning if they've needed it. And we get to this point where we're just worried about fluid balance, and the urine output is not good enough or hasn't established in order to maintain fluid balance. You can often switch to this when you notice on the drug charts, on the result charts, that the phosphate has been needed to top up regularly, and there's lots of magnesium going in, and that's usually because we're probably over dialyzing them even at the lower doses, and that that sometimes is an indication to switch to SCUF if you want to manage fluid balance. So it looks a bit like this. These are Baxter slides, I think, originally, but essentially the way it works, and it's red just to know that it's coming away from the patient. It's not actually arterial. This is all venous. So this comes from your vas cath, which is sited in a suitable vein. So usually right internal jugular is probably the best, but you can use the groins and the left internal jugular if you wish. But don't do subclavians, because that increases the risk of stenosis, which can have an impact on patients later on if they need fistulas and things. So blood comes in. We'll talk about the pre-blood pump in a bit. There's an access pressure to make sure it's not too negative, and that we're not trying to suck blood against a wall. We're not getting enough flow through. So that just checks the access pressure. If it gets very, very negative, we're not getting enough blood coming in there, and that might be because the patient is extremely dry, or usually it's because the vas cath is sitting against the wall of a blood vessel and it can't suck enough blood in. You have a blood pump, which is a roller pump. So you've got some flexible plastic tubing, and the roller pump moves blood along, and roller pumps are good because they cause less hemolysis, and then that is then pushed to the hemofilter. So that's your pressure gradient there. And then, as I mentioned before, as I showed before with the filter, blood is squeezed in here, fluid is squeezed out, and it comes through the out the effluent end into the effluent pump. The blood is then returned to the patient with a couple of safety devices. You've got an air detector, because if this is cracked and no one's noticed, or there's a little leak, or there's an open tap that's drawing in air, you don't want to be bolusing large quantities of air back to the patient. That would not be optimum. So that is essentially scuff in a nutshell. You can control how much effluent it comes out through a bit of a gradient between how much blood you're pumping in, and you can then speed or slow this pump down as well. If you want to increase the life of the filter, because you can imagine if somebody's got, let's say for argument, they've got a hematocrit of 40%, so 60% of that is plasma. If you take half of that plasma off, you're going to be hemoconcentrated at this end. So your blood is going to go from a sort of watery stage to a slightly more jammy stage, not completely, but it will reduce the life of the filter. So what you can do is you can add pre-blood pump fluid just to increase the life of the filter. Now, you can imagine it will reduce the efficiency of the filter, but because you're running it continuously, it doesn't matter too much. Obviously some of that pre-blood pump fluid will end up in the effluent, but that will also take some of the plasma as well. So it does reduce the efficiency, but it's can be useful to increase the filter life. You can also add other things here. You can add heparin if you wanted to. Often heparin is controlled by the syringe pump. So that's a sort of basic building block of the first stage, I guess, of the renal replacement. So the next one is continuous hemofiltration, and again you run a little bit more convective flow with some extra fluid here, and again we get our usual water and solute removal by ultrafiltration, but you add a certain amount of convective flow by adding some replacement fluid, which we'll talk about now. So this has got slightly more complicated, but you can remember from the previous slide, you've still got your pre-blood pump here, you've got your effluent pump here. Usually the pre-blood pump in this stage has a different role, usually for anticoagulation. And you've got a replacement pump pre, and you've got a replacement pump post. And on our system, we have pre and posts. And again, what you do here is you add volume in here, which helps with convective flow, reducing efficiency, but not making its efficiency terrible. But it does improve the life of the filter to allow you to achieve that 24, 36, 48 hour continuous filtration without clotting. About 15% of this fluid is lost in the effluent, but because the machine is weighing all of these different fluid bags, it's able to work out how much fluid we're taking off at any one time. So if it knows that for argument's sake, you're adding another 15 mils a minute from the replacement pump, it's able then to calculate how much is being weighed into the effluent pump. How much is over that will tell you how much you're actually taking off the patient. So in order to counter your hemoconcentration at the end of the filter, then we add replacement pump. And when we talk about negative on the filter or neutral on the filter, if all we're trying to do, if we've got somebody who's gone into an AKI, who's been resuscitated for hemorrhage or hypovolemia, and you don't want to take any fluid off the patient, what you do then is you ask the machine to be neutral, and what the machine will do then is it will split the ratios of fluid in and fluid out against the effluent. So if you're putting if you're taking 70 mils off here, losing 30 mils from the replacement, it will make sure that the replacement pump is balanced to mean that you end up with no fluid off after the maths has been done on it, basically. Again, you're improving the filter life, and you're also then able to have quite a bit of control on fluid. If you reduce the replacement pump blood speed, you will potentially take more fluid off the patient, and the software on the machine can program that, and they usually split in a certain way depending on the manufacturer's preferences. I think it's 15%, 85%. I think that's the split we use on our machines. So that's hemofiltration. With dialysis, we don't tend to do CVVHD. We tend to do CVVHDF. Now, I'm mentioning dialysis because I'll go on to this now. We've got a similar building block as before. You remember this from the scuff, but we add dialysate. Now, this is a bit like the intermittent hemodialysis system that we use at the bedside on ICU, or that they use in the outpatients. So the patients come in, they get hooked up to their fistula or their Tessio, and they get dialyzed. Now, these pumps run much faster than the continuous pumps, but this is a modality that we can choose in our filter machines, but we just don't bother. We don't have the protocol for it. We don't really feel that's necessary. So the difference here is with our system, we use hemodiafiltration. So what we're adding is the replacement pumps, the pre and the post replacement pumps, in addition to the dialysis as well. So then it's called hemodiafiltration. So when you set somebody up and you write that dose on the ICU, that's what we're actually giving, is dialysate and an additional convective flow. So we've got 1, 2, 3, 4, 5 then usually running on the patient. This is an extremely efficient way of dialyzing somebody, and sometimes you can bring the electrolytes down very, very quickly, which can be dangerous as well. So these are considerations sometimes that we need to think about, but particularly if we've got people who've got ureas of 70 odd, bringing those down too quickly can cause disequilibrium and can cause cerebral edema. So that's CVVHD, and then with the additional bags on the pre and the post, that becomes hemodiafiltration. So you get diffusion, you get a concentration gradient, a bit like the Luper-Henle with the dialysis, and then you also get the ultrafiltration and the convective flow with the pump and the pre and post fluids. Does that make sense to everybody? Okay, we'll perhaps have a chat at the end. Okay, so dosing. The other thing we write up is the dose. And what does that mean? Well, it's essentially, it's the total effluent sum expressed in mils per kilo per hour. So it's a measure of the clearance that these patients are subject to when we dialyze them. And it's expressed in sort of mils per kilo per hour. So I sort of see it a bit like the GFR. And there was a lot of debate at the beginning of the century about how much should we give, because there were some centres, Belomo and a few of the others who said, oh, if we give them a lot higher dose, we seem to make them survive a bit longer, their mortality is lower. So that triggered a load of research, and it really doesn't, unfortunately, running them very high flux can sometimes be useful for certain cases, but generally the sort of dose around 20 to 25 mils per kilo per hour is actually okay. We tend to pick 25 because with an 80% downtime, the sort of cutoff is around 20-21. So if you get 80, if you've got a filter that's up 80% of the time, you'll get 20. So if we always set 25, even with interruptions for things like CT scan and what have you, you should get the minimum of 25. We do write 35. Sometimes we push it harder if there's a big acid load that we're not clearing quickly and that's causing cardiovascular compromise. We might push the dose up a little bit. So that's where we are with dose, and I think we're pretty supported in the literature to run between 20 and 25 to 35. Then next thing is anticoagulation. So we can, this is essentially the four things that we can give. We can give nothing, which we do sometimes if people are already auto-anticoagulated, coagulopathic for various reasons. We can use epoprostenol, which is local anticoagulation, and that effectively interferes with platelet aggregation in the filter and prevents clot initiation and helps improve filter life. we can use heparin, and that can be heparin on the filter that then becomes systemic to the patient, and we are aiming at an APTR of 1.5 to 2. Sometimes if patients are in AF or they've got PEs and we're worried about stopping heparin when they're not on the filter, we can run systemic heparin, and these patients can be put on and off the filter without any heparin in the filters per se, because it's been run systemically. And then finally we have citrate. Now citrate mops up calcium, and calcium is clotting factor 4. And you remember, you know, if you take a bag of blood that you're going to give patients, it's nice and liquid because it's ACD blood, adenine, citrate, and dextrose. The dextrose for the red cells, as the adenine, I think, and the citrate is there to mop up all the calcium, which is why massive blood transfusions lead to hypocalcemia. But in this situation for filtration, you get local anticoagulation, which is extremely effective. You can keep filters going for their manufacturer's recommended life, which is usually 72 hours. Possibly there might be a bit of an outcomes benefit to running people with citrate over heparin, but heparin might have a toxic placebo sort of effect because it has anti-inflammatory and pro-inflammatory effects, which may not be helpful in certain stages in sepsis. So debates out on that one. We'll let the academics work on that one, but citrate can be extremely useful if you have patients who let's say upper GI bleed that you're still worried about. They've just had that treated, or they're post-op and they've had massive hemorrhage and they've gone into an AKI. You may not want them systemically heparinized, and you also want them to be cleared. So you may not opt for nothing in that situation. You might want to run a bit of citrate. So citrate is added to the circuit. Then as it leaves the patient, calcium is added to a return line, which is very separate and is added a bit more distally to the patient, sometimes peripherally as well. We try and keep it all in one loop because of the risk of not returning calcium back to the patient and giving them symptomatic hypocalcemia. Citrate's metabolized in the Krebs cycle, so it does produce a certain amount of energy for the patients, which the dietitians always have to scratch their heads about because it's not the most straightforward thing to calculate how much extra energy they're getting from citrate, but it is useful. There would be probably a few contraindications to citrate, obviously allergy, but some patients with liver failure don't tolerate citrate. I think they're a bit nonchalant about it in the liver units, but it's just something to bear in mind. And that's really everything I've got to say about renal replacement therapy. Hopefully there's a bit of time for some questions now. This is a QR code. There's a nice little paper by Tandulkar from Chest in 2019, I found. If you scan that QR code, it'll take you to the paper. If you want to take a screenshot for the DOI, if you can't scan that number, and I can make that paper available. I can send it to Tuber if there's anybody who's missed that. There you go.
Thank you very much, Liam. That was fantastic and very thorough. So please, questions to Liam, please, in the next 5 minutes, or if there is any.
And
if there is no question, can I just ask something from the audience? Is that something what you wanted from a consultant presentation, this overview, or do you want the consultant presentation more into the literature or more hands-on? Can somebody answer this question, please?
Yeah, that was great. Although I've got a little echo.
got any question? Okay.
Any questions? No questions? If there's no questions, we will thank Liam to this wonderful presentation, and thank you very much for your time and effort.
No, thank you.
Very much appreciated. And
Pleasure.
Lipika, are you available now to present?
Hello. Yes. Hi. Am I audible now?
Thank you. It's all yours now.
Yeah. Am I audible?
Yes, I can hear you, just about.
Share my screen.
And also, whoever did not put his her name or his name on the list on the chat box, please do so, because we are running. We need to see who is here, who is not. So we are running a register. Yeah, I can see a screen now. Yeah.
Can I begin? Can I start? Hello.
Yes, you can start. It's all yours now.
Hello. Good afternoon. I'm Lipika, and I'm going to present a few important topics about respiratory physiology. So I'm going to start with oxygen transport and then move on to alveolar ventilation, dead space, shunt, lung compliance, and hypoxic pulmonary vasoconstriction. So oxygen transport. So ventilation of the lungs supplies oxygen to the alveolus, and this oxygen then diffuses from the alveolus across the alveolus to the pulmonary capillaries, from where it is carried by blood to the different parts of the body, to the cells. And from the capillaries, it finally diffuses up to the cells, to the mitochondria. This is best explained by oxygen cascade. So, what is oxygen cascade? It is essentially the oxygen. It describes the sequential reduction in the partial pressure of oxygen from the atmosphere to the cellular mitochondria. So, at sea level, the atmospheric pressure is approximately 100 kilopascal, and oxygen, it's 21% of oxygen. So, when we inspire the oxygen from the atmosphere, it's approximately 21 kilopascal of oxygen, and this sequentially reduces as the oxygen goes down into the mitochondria. So in the upper airway,
Hi, sorry, Lipika.
Hello.
Hi, sorry, the slides are not moving.
I'm just going to explain this cascade. So there's
Lipika, your slide doesn't move.
Is it still on the first slide, transport?
Yeah. It's a one
Yeah,
only.
it's on the content page.
Content slide,
Okay.
but doesn't move the other slides.
Is it moving now?
No.
I think you need to share. You need to share the other bit of the screen. I think because you've shared the just the slide deck rather than the presentation.
Is my screen moving now?
It's
No,
gone
Lipika.
now.
It doesn't. It has all removed now.
Okay. Tuba, do you mind sharing the screen? I mean, I can't really.
Okay, now it's moving. It's fine.
Now it's moving. Yeah.
Okay.
Okay.
Slide
There you go.
Yeah.
Okay, carry on. Yes, thank you.
Yeah. So, I was talking about when we inspire the oxygen, it gets humidified in the upper airway, and the partial pressure of oxygen then comes down to 20. And when it goes into the alveolus, it mixes with the dead space gases, and the partial pressure of oxygen in the alveolus is 15. And finally, into the mitochondria, the partial pressure of oxygen comes down to around 1 to 2 kilopascals. So, how is oxygen carried in the blood? It is mainly combined with hemoglobin, and some amount is dissolved in plasma. So, the oxygen content of the blood is basically the sum of the oxygen bound to hemoglobin and the oxygen dissolved in plasma. So, each gram of hemoglobin combines 1.34 mils of oxygen. So, we can calculate the oxygen content by multiplying the hemoglobin with the oxygen saturation, which in the arterial blood would be 100%. And combining it with the dissolved oxygen, which depends upon the partial pressure of oxygen in the blood. This is an example to show that. For example, in arterial blood, if the hemoglobin is 15 grams per deciliter and the saturation is 100%, we can calculate the arterial oxygen content by multiplying hemoglobin with the oxygen saturation and then adding the dissolved hemoglobin, which comes up to around 20.4 mils of oxygen per deciliter in arterial blood. Similarly, in venous blood, it comes around 15.2 mils. And this difference is just 5 mils of oxygen per deciliter. And this can be, we can calculate the oxygen delivery by multiplying it with the cardiac output. So moving to alveolar ventilation, the volume of air entering the alveoli per breath is alveolar ventilation. To be precise, it's the tidal volume minus the dead space volume. This can be best explained by the alveolar gas equation, which is used to calculate the partial pressure of oxygen in the alveolus. The partial pressure of oxygen in the alveolus mainly depends upon the partial pressure of the inspired oxygen and the partial pressure of carbon dioxide in the alveolus. So when we inspire the oxygen, the FiO2 remains constant everywhere, but the atmospheric pressure changes with altitude. And hello. Hello.
We can hear you. It's all good.
Yeah. Sorry. Yeah. So when we inspire oxygen at sea level, at sea level and at a higher altitude, the inspired oxygen, the partial pressure of the inspired oxygen changes. And that is why the alveolar gas equation is helpful to calculate the partial pressure of oxygen in the alveolus. Moving on to dead space. What is dead space? Dead space is the volume of inspired gas that does not take part in gas exchange. There are two main terms. One is dead space and one is shunt. First, I'll speak about dead space. So dead space is further divided into anatomical dead space and physiological and the alveolar dead space. The anatomical dead space mainly constitutes the conducting airway. Hello. That is first 16 generations, the trachea, bronchi, bronchioles, and the terminal bronchioles. It also includes the upper airway, that's mouth, nose, and pharynx, and is approximately around 2 mils per kg. The other part of the dead space is the alveolar dead space. It constitutes the alveoli that are ventilated but not perfused, and therefore no gas exchange occurs. Combination of alveolar and anatomical dead space is known as the physiological dead space. Next important term is shunt. Shunt is somewhat the reverse of dead space. Shunt is it's an extreme form of ventilation perfusion mismatch, whereby blood enters the arterial system without passing through the ventilated areas of the lung. So in that dead space, there is ventilation but no perfusion, whereas in shunt, there is perfusion but there is no ventilation. So shunt can further be, it can be intrapulmonary or extrapulmonary, and physiological and pathological. The main pathological causes of shunt are the lung collapse or consolidation, where there is no ventilation but there is perfusion. Whereas physiological causes of shunt could be the bronchial artery blood passing into the pulmonary veins and the coronary venous blood draining into the left ventricle. An important cause of extrapulmonary cause of shunt is seen in mainly cyanotic congenital heart disease, where there is right to left intracardiac shunting. We'll speak about West zones next. I'll speak about West zones next. They are nothing but the physiological boundaries in the lung that are based upon the relationship between the pressures in the alveoli, arteries, and veins. So there are basically three zones, zone 1, zone 2, zone 3. In an upright, healthy individual, the apex would be zone 1, where the alveolar pressure exceeds vascular pressure, resulting in capillary collapse and no blood flow. Zone 2 would be somewhere in the middle lobe of the lung, where the blood flow gradually increases. The arterial pressure exceeds the alveolar pressure, and which exceeds the pulmonary venous pressure. Whereas in zone 3, both the arterial and the venous vascular pressure are greater than the alveolar pressure. So what is the significance of these rest zones? In a healthy adult, the zone 1 does not exist because the arterial pressures are just sufficient to raise the blood to the top of the lung and exceed alveolar pressure. However, if there is severe hypotension following major hemorrhage, zone 1 may be present. Secondly, during exercise, when the pulmonary artery pressure is high, the zone 1 is almost eliminated, and the zone 2 moves upwards and zone 3 moves towards zone 1. Also, in positive pressure ventilation, the alveolar pressures are increased, which can result in substantial areas of lung to fall into zone 1. And this is in the upright position. But if the person is lying in left lateral or right lateral position, the apex would correspond to mainly the non-dependent part of the lung. So moving on to the next topic, that is lung compliance. So compliance is a measure of distensibility, the ease at which something can be stretched. It is defined as a change in lung volume per unit change in transpulmonary pressure. It is best described using pressure volume curves of the lungs under static conditions when there is no gas flow and the respiratory muscles are relaxed. So the normal lung compliance is approximately 200 mils per centimeters of water, and it mainly depends on the surfactant. So in neonatal respiratory distress syndrome, the lung compliance is greatly reduced due to insufficient surfactant. And this lung compliance can be divided into two types. One is the static compliance and one is dynamic compliance. Static compliance is mainly monitors only the elastic resistance, that is the resistance offered by the alveoli being stretched and the interstitium and chest wall being moved. And it can be used to select the ideal level of PEEP during mechanical ventilation. Whereas the dynamic compliance monitors both elastic resistance as well as the airway resistance, which in turn depends upon the gas viscosity, the density, length, and radius of lumen, and the gas flow rate and the flow pattern. Next, I'll speak about hypoxic pulmonary vasoconstriction. It's basically a reflex contraction of the vascular smooth muscles in the pulmonary circulation in response to low regional partial pressures of oxygen. It is a protective physiological reflex that aims to direct blood away from the hypoxic areas of the lungs to areas with better ventilation and oxygenation, thereby to prevent shunt. And it's an important mechanism for matching of regional perfusion and ventilation in the lungs, and thus acts as an important physiological process for maintaining oxygenation. So there are various factors affecting hypoxic pulmonary vasoconstriction, that's HPV. Hypercapnia increases pulmonary vascular resistance. So it prevents, helps HPV. HPV is potentiated by acidemia, and alkalosis leads to attenuated HPV and decreased pulmonary vascular resistance. HPV is also an important phenomenon in one lung ventilation, where it acts to it prevents shunting. Hypothermia also inhibits HPV, and it is potentiated by hypothermia. And lastly, at birth, HPV is one of the important mechanisms which helps in the transition from fetal to an adult circulation. That's about it. Thank you.
Thank you very much. Thank you very much. Wonderful presentation, very thorough. Any questions? No questions? And thank you very much, everybody, for the attendance. I'm very, very, very pleased. There was at some point we were 33 on that call, and this is how it needs to be. So please liaise with me or liaise with Tuba if you need to swap your presentation, and if there's any problem, just let us know. And again, make a note on the 9th of February, where we will do an in situ ITU simulation on this teaching program. Thank you very much, everybody, and have a lovely day.
Thank you.
Thanks,
Bye.
Harry. Bye-bye.
Bye-bye. Thank you, Liam. Thanks.